and welcome to the Demographic Dividend Community Session. My name is Elizabeth Leahy Madsen with PRB. On behalf of my co-chairs, Dr. Alan Kabagenyi, Dr. Jean-Christophe Rusatira, and Kaitlyn Patierno, thank you for joining us for this session. Today's session has been designed to assess and respond to the reverberating shocks across sectors caused by the COVID-19 pandemic as they relate to the demographic dividend. By upending the delivery of health and education services and threatening economic livelihoods, the pandemic has not only created an array of short-term crises, but also raised dramatic implications for countries' progress towards long-term development goals, including the demographic dividend. This session will explore implications of the pandemic across 4 pillars of the demographic dividend: family planning, education, the labor force, and women's economic empowerment, each of which is imperative to building human capital. In addition to documenting what we know so far about the negative consequences of this crisis, we will also discuss innovations that countries and their partners are developing to mitigate and recover from these challenges and promote more resilient human capital development moving forward. We have a very distinguished panel of speakers with us today, many of whom are kindly sharing fresh and emerging results from groundbreaking research studies that are still in progress. The panel will begin with opening remarks from Dr. S.K. Sikdar, an advisor in the Maternal Health and Family Planning Division of the Ministry of Health and Family Welfare in the Government of India. We are delighted that Dr. Sikdar is available to share India's experience with the human capital effects of COVID-19 and implications for attaining the demographic dividend. Our discussion of the 4 pillars of the dividend will begin with Dr. Aurélie Bruni, a senior scientist in the Health Services Research Division of FHI 360, who is the senior research lead for Research for Scalable Solutions, an implementation science project on family planning funded by USAID. She will present results from an ongoing study on the impact of COVID-19 on unintended pregnancies and family planning availability and access in 4 countries. Our next speaker is Carolina Cardona. Ms. Cardona is a PhD candidate in the Department of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health. Her presentation will share results from an ongoing study of how women's economic empowerment has changed during the COVID-19 pandemic. We will then hear from Dr. Prachi Srivastava, tenured associate professor specializing in education and international development at Western University in Canada, who is also a member of the World Bank Expert Advisory Council on Citizen Engagement. She has been working on the global education emergency caused by the COVID-19 pandemic for nearly a year, and will share evidence about the contours of the long-term effects facing the education sector. The 4th pillar of the demographic dividend will be addressed by Professor Latif Dramani, Professor of Economics at the University of TS and coordinator of the Center for Research in Economic and Applied Finance of TS, or CREFAT. He will share results measuring the impacts of COVID-19 on the labor force in West Africa and discuss how these results are informing the government of Senegal's plan to recover from the crisis. Professor Dramani will be presenting in French, and simultaneous English-French translation is available throughout this session. To conclude our panel, Dr. Bernard Onyongo will offer closing remarks on the impacts of the pandemic across the pillars of the demographic dividend. Dr. Onyongo is the Senior Research and Policy Analyst at the African Institute for Development Policy, AFIDEP, and leads its Population and Sustainable Development thematic area. The co-chairs of the session hope that you will find these presentations as interesting and engaging as we do, and we encourage your participation in the discussion portion at the end of the session. Because of the size of the group, we will be utilizing questions and comments that are submitted in advance through the Q&A feature of Zoom. At any time during the presentations, please feel free to submit your question for any of the panelists, and the moderators will place it in the queue. With that, I turn the session to our distinguished panelists. Thank you very much.
Thank you, Liz, for that introduction. Respected dignitaries, colleagues from across the world, a very good morning, afternoon, or evening to you all based on from wherever you are hooked in. It is indeed a great privilege and pleasure to have been invited to deliver the opening remarks in the demographic dividend session and being part of this apt forum of Not Without Family Planning. Before immersing into the topic, let me dwell a few significant minutes on India's effort in containing the pandemic and how we leveraged our resources to launch frontal attack on it. Being the country with the second highest caseload, exceeding 10 million, India's response had been swift, decisive, delineating a unified command line in a whole of government approach, enrolling all wings and ministries of the government, not only in terms of unity of thought, but magnitude of actions, which I'm sure has very few parallels globally. It has been global, it has been hailed globally, not only by WHO and World Bank, but also many other European countries as one of the best practices in the pandemic period. The results are there for everyone to see. As against 184 million tests conducted till death, our positivity rate is only around 2%. Cases per million are around 7,000. Recovery rate is over 96,000. And the most important, mortality rates are down to only 1.4%. Our daily numbers to have dwindled to a meager 15,000 against a peak of 100,000 3 months back, which is remarkable considering our huge population of over 1.3 billion. These are some of the best figures in the world, and a salute to the strength of the Indian public health system, which rose to the task manfully and is still delivering. We are now bracing ourselves well for a possible resurgence that has happened in the Western and Far Eastern world by systematically launching the largest immunization campaign in the world ever, targeting 300 million people in the first phase. This has been ably aided by India's envious vaccine manufacturing might. We already have started mass production of 2 vaccines indigenously, which have already been given approval for use and are also being sought globally. Together with this, we also have 4 more potential vaccine candidates at various stages of clinical trials, waiting to make a landfall around the middle or later part of this year. In a magnanimous statement delivered at the United Nations, our Honorable Prime Minister Shri Narendra Modi has said, and I quote, "As the largest vaccine-producing country of the world, I want to give one more assurance to the global community. Today, India's vaccine production and delivery capacity will be used to help all of humanity." To that effect, an array of countries have been lined up, extending from Asia, Africa, and Latin America for priority delivery of the vaccines. Demographic dividend in the context of COVID-19 is of specific relevance for India. It is all the more significant since, as the second most populous country, with a fertility level higher than that of China, India is poised to reap the benefits of the highest demographic dividend in the coming decades. COVID-19 has impacted us all in different ways. In fact, the pandemic has significant lessons for mankind in all the domains, including health. Before actually pondering over the challenges that may hit us, let's be mindful of the fact that COVID is not the first and definitely won't be the last to savagely hit the human race. Pandemics and emergencies evoke certain focused responses, and in fact, any pandemic or emergency is a test for the competence and resilience of the country's governance and systems, and above all, its people. This unprecedented crisis has also presented us with an opportunity to revisit how we conceive, design, regulate, build, and operate strategies to the present, for the present as well as the future. Home to nearly a fifth of the world population, with more than 65% adolescent and reproductive health population in India, we are adding over 12 million people to the working age population each year. The country is therefore well aware that it is imperative for us to meaningfully employ its workforce, drive the policies that can ensure universal access to health, invest in education and infrastructure. India's population is expected to continue to grow until the mid-century due to population momentum. However, the population growth will come to an end soon. The number of children in India peaked more than a decade ago and is now falling as per the UNDSA projection. The youth population in the age group of 15 to 24 years will decline from 233 million in 2011 to 227 million in 2036. However, the proportion of working age group, that is from 15 to 59 years, is expected to increase from 61% in 2011 to 65% in 2036. For India, this is more important as the window of demographic dividend opportunity in the country is already open and is available for the next 4 decades, longer than any other country in the world. Education plays an important role in driving the country's human capital. Due to the pandemic's impact, most children across the globe have been out of school, translating into considerable on-ground losses for countries. the challenges haven't deterred our Honorable Prime Minister from reiterating a target of making India a $5 trillion economy by 2025 from the current levels. Thriving and unsustainable economic growth trajectory of $5 trillion needs building of knowledge economy. Just before the pandemic, India also came up with an ambitious national education policy which focuses on keeping the girls at school and emphasizes foundational literacy and numeracy, extracurricular, vocational streams, etc. Amid this pandemic, India laid special emphasis on education, and in the current year, the country witnessed an increase in the budgetary allocation for the education sector by 5%, amounting to 14.2 billion US dollars. Health is one of the key determinants of development. India is making universal healthcare a reality through intensifying its pre-pandemic efforts under the Healthy in India initiative. This was envisioned to achieve comprehensive primary healthcare by providing platforms for services through development of 150,000 health and wellness centers by December 2022. India's latest 5-year plan identified universal health coverage as a key goal, allocating as much as 70% of the health budget to the primary healthcare in pursuit of universal health coverage. Investments in the health of girls and women have the potential to speed up in a country's demographic transition and to increase the size of the demographic dividend. The government of India is working tirelessly to ensure that the Indian health system addresses the pandemic and simultaneously ensure that essential RMNCAH plus nutrition services reach the community. To that extent, it has mandated that under no circumstances should there be a denial of essential services to women, newborn, children, and adolescents, and that critical services to them are provided irrespective of their COVID status. India is the first country in the world to have launched a national family planning program way back in 1952. The program has since come a long way and is currently redesigned to not only attain population stabilization, but also to considerably reduce maternal, infant, and child mortality and morbidity. Family planning allows people to stay healthy and free of reproductive, sexual, and mental health issues and ensures that they stay in school and complete education. It also gives them the freedom to enter the job market or start their own enterprise, be more productive at work, increase savings, and prioritize spending on things that improve their lives. It further allows the young to start a family at a time when they can offer the best opportunities for their children. Therefore, family planning impacts all the dimensions of human capital. India has experienced a substantial decline in all its major mortality indicators concerning the children as well as the mothers. Vaccinations too have played their part in the improvements in numbers. The childhood vaccines also have the virtue of promoting better school attendance, a better cognitive function, and better adult health, all of which tend to make vaccinated children more productive and therefore higher earning adults. India's universal immunization program is one of the largest public health programs, targeting close to 27 million newborns and 29 million pregnant women annually. The fertility rate too has declined sharply from approximately 6 children per woman in the 1950s to 2.2 today. The percentage of girls married below the age of 18 years and the teenage fertility has also dropped by half over the last decade. India is geared to continue with this progress, and a three-pronged strategy is envisaged for improving human capital and efficient utilization of demographic window by strengthening family planning services and access, promoting infant and child survival, and improving girls' education with increase in female workforce participation. Girls' education can serve as both an indicator of development and an instrument for promoting fertility decline. The government is now ensuring inclusive growth for all through its ambitious aspirational districts program, where health and nutrition and education forms an important pillar under the core areas of focus with a view to remove inequity. Health workforce is the backbone for the COVID response in the country, so the national government is ensuring the health and well-being of the frontline workers. In addition, a substantive health insurance package has also been revised for the healthcare providers. The ongoing pandemic may have forced us to press the pause button for some time, but we are now accelerating to make up for the lost time. Never before in the history of modern world have governments, industry, and civil society been united and forced to reassess how we lead our lives, work, and plan for a safer, healthier, collective future. This crisis also demonstrates that governments and individuals are capable of strong and rapid action in the face of an overwhelming challenge. global cooperation will be essential for supporting vulnerable population and achieving a sustainable and inclusive global recovery. And the concept of a global village leading countries to think globally and act locally is now more relevant than ever. In India, with a one-time huge opportunity of demographic dividend, we as a country stand strong for this cause. Thank you very much for a very patient hearing. And again, greetings from the Government of India.
Okay, so good morning, afternoon, or evening to all. As Liz said, today I will be sharing preliminary results from a study conducted under the R4S project on the implications of the COVID-19 pandemic for family planning and unintended pregnancies in Malawi, Nepal, Niger, and Uganda. The pandemic poses challenges to voluntary family planning care, through health system disruptions, people's fears of becoming infected while accessing services, and government restrictions and containment measures. To obtain data on women's experiences and identify potential gaps in family planning availability and access, we set out to conduct a prospective cohort study with women ages 18 to 49 using VIAMO 321 service in 4 countries. Specifically, we wanted to document unintended pregnancies, track changes in modern contraceptive use during the pandemic and recovery process, examine women's ability to obtain their preferred method, and describe barriers to family planning access and use. This is not a nationally representative study because the recruitment approach uses VIAMO 321 service, which is a free on-demand dial-in service that mobile phone users can use and call into to access information on a range of topics. So for example, press 1 for health, press 2 for agriculture, etc. The study has 2 components. The first one is a brief one-time survey with women calling into VIAMO 321 service. And the second one is a panel survey. For the panel survey, we are calling women back who said they were currently using a modern method other than permanent method, and women who are not using a modern method, but say they are not wanting to get pregnant in the next 2 years. All data collection is done through VIAMO's platform using interactive voice response. Today, I will be sharing 321 and round 1 results from Uganda, where data collection is 17% complete. So obviously there is more to come, but we already have some rich findings with some clear trends and implications. This first set of results on unintended pregnancies comes from the 321 survey. There were 24% of women in the sample who were pregnant, and these are all pregnancies that occurred after the beginning of the pandemic in March. You can see in the pie chart that 45% of pregnancies were planned, and we asked all women with unintended pregnancies whether the pandemic affected their ability to avoid or delay getting pregnant. And you see from the shaded areas in the chart that 46% of all pregnancies were attributed to reasons related to the pandemic. And on the right, you will see that these reasons had to do both with supply side constraints, that would be the pink bars, as well as with fears of becoming infected, which are the green bars. And unfortunately, we do not know what the gray bar for other refers to. All the remaining results come from the panel survey, and the response rate for the panel survey was 30%. We asked women retrospectively what they were doing for family planning prior to the beginning of the pandemic in March, and you can see this on the left side of the graph. And then we compared this to what they were currently doing for family planning, which is on the right side. And you see here that modern contraceptive prevalence between the 2 time points decreased from 57% to 52%, and there was an increase in particular in the proportion of women that were not doing anything for family planning. Then if you look at the contraceptive modern method mix on the right, the share of short-acting method increased from 43% to 51%, with relative gains in injectables, pills, and condoms. Next, we looked at source of supply, and if you compare the two charts, you see that there was a 6% reduction in the proportion of women sourcing their method from public facilities, and there were increases in the proportion of women supplying in particular through drug shops and community-based platforms. Again, we asked women reasons for the choice of their current source of supply, and you can see that it was a combination of supply side constraints in pink and fear of infection in green. Moving on to the next objective of the study, we wanted to know if current users who have initiated or resupplied their method since COVID had been able to obtain their preferred method at the last episode of use. Overall, we found that 82% of women had been able to obtain their preferred method. The sample size here is still fairly small, and the results may change as more data come in. But for now, the main reason for not being able to obtain their preferred method was the method not being available and not having enough money. The last set of results here is about non-users of modern contraception, including traditional method users and women who are not doing anything for family planning. We asked these women if they had wanted to obtain a modern method since the beginning of the pandemic in March, and if so, if they had tried obtaining one. And you see that 53% of these women had tried to obtain a method, and an additional 12% had wanted to obtain a method but had not tried. The main reason for not trying was perhaps logically fear of infection. And for those who had tried but had not been able to obtain a method, the main reasons were not having enough money and the method not being available. So you see here the timeline at which we expect the full results for Uganda and other countries to be available, and these results will be shared at the link that you can see on the slide. In addition, we will be organizing results interpretation workshops in each country to identify potential program adjustments based on our results. Obviously, what I shared today is still preliminary, but it offers some early insights. First, the findings that we have and are going to continue producing provide direct evidence to support global estimations of the impact of the pandemic, for example, by the Guttmacher Institute. As we see, there is a decrease in modern contraceptive prevalence and that there are unintended pregnancies attributed to the pandemic. Second, the pandemic is obviously a time of crisis, but it's also a time of opportunity for us to innovate and strengthen approaches that can serve to bridge gaps in service delivery now, but could also continue beyond the pandemic. And lastly, I think it's important to realize that we are going to need holistic approaches that not only address constraints in the supply chain and in terms of service delivery, but also address other challenges that are associated with demand, including in particular financial barriers and fear of infection. So I will stop here for today. Thank you very much for your interest in the presentation, and please stay tuned for more results.
Thank you, Aurélie, for that great presentation, and thank you, Liz, for the introduction. I will now go into presenting our study that analyzed women's economic empowerment changing as a result of COVID-19. I'm going to be presenting results from our PMA survey. This is a joint work with Phil Anglowicz, Elizabeth Gamerson, and Michelle Decker. I'll start by providing some background information. And what we've seen overall in the literature is that empowering women has the capacity of increasing the economical gains of a country. Moreover, empowering women is an essential factor for the realization of women's rights, and it has also been linked to a range of development goals, such as maternal health, children's education, and children's health and nutrition. When COVID-19 hit our world last year, the response from many governments was the implementation of strict lockdown measures that limited individuals' ability to leave their households in order to control the spread of COVID-19. Given those measures, it is a fair question to ask ourselves, so what is the impact of this shock or of this interventions to the economy and also to women? What we've seen so far from high and middle income countries is that the economic consequences have been heavily affecting disproportionately low-wage manual workers, women, and the poor. We've also seen evidence across 4 countries in sub-Saharan Africa that 87% of the women indicated that their households experienced some sort of income loss due to COVID-19. So given that background information in this study, we intend to measure what is the extent of the impact of COVID-19 on women's economic empowerment across 4 countries in sub-Saharan Africa, and also to identify what are the socio-demographic correlates of women's economic empowerment. To address our questions, we leverage on an ongoing survey that we conduct here at Hopkins, which is Performance Monitoring for Action, or PMA. As of 2019, PMA shifted to a longitudinal design where it collected information of women of reproductive age, and then it conducted a follow-up interview over the phone 1 year later. Our first round of data was implemented between October 2019 and January 2020 through an in-person interview. This interview happened just before COVID. The original PMA design intended to collect a follow-up interview over the phone 1 year later. However, when COVID-19 hit last year, we tweaked PMA design and implemented a COVID-19 specific survey that was conducted between June and July. Our countries that are part of this first wave of data that we called phase 1 were Kinshasa in DRC, Lagos in Nigeria, and we have a national representative sample from Burkina Faso and also from Kenya. Our COVID-19 survey was structured around 9 modules, and on this presentation, I'm going to show you some of the socioeconomic measures that we've collected. Our sample consisted of approximately 1,200 women that were distributed across our 4 countries as shown in this table. As with any longitudinal study, we lost some of the women to follow in the follow-up questionnaire. Our attrition rate ranged from 75% in Burkina Faso to approximately 94% in Kenya. In order to control for attrition, we implemented inverse probability weights on our estimations, and we've also implemented IPWs to control for the fact that a woman needs to provide a phone number to receive the follow-up interview. I'll go now into presenting our methods and measures that were used for this specific study that I'm presenting here today. To proxy for women's economic empowerment, we leverage onto questions that were asked to women that are either married or living with a partner. This question was asked both at the baseline survey and also at the phone follow-up interview. Women were asked to answer who usually makes the decisions about making household purchases for daily needs. A woman could indicate that she is the decision maker, her husband or her partner is the decision maker, they make the decisions jointly, or someone else makes such decisions. In this presentation, I'm going to focus on presenting the results of one of our outcomes. Our first outcome of interest limited our sample to include only the women that stated at the baseline questionnaire that the woman was the decision maker of making the household purchases for daily needs. And we're interested in knowing in the follow-up survey, which was collected during COVID, if that woman was able to remain her decision-making power, if it shifted to her partner or someone else making the decision, or if it shifted to a joint decision-making. To identify the characteristics associated with change in our outcome of interest, we implemented a multinomial logistic regression model with site-fixed effects, and we've controlled for individual and household characteristics. On this slide, you can see a figure as an example for Kenya. In this figure, this is depicting how we define our outcome of interest. As I mentioned earlier, we're only going to focus on this presentation on women that stated that they were the decision makers at baseline. Here we can see the pink bar that is surrounded by that red box, and we're interested in knowing how those women transition to their other 3 possibilities in the follow-up survey. Here you can see some summary statistics of our outcome of interest, and you can see that there seems to be 2 patterns across our 4 countries. Pattern 1 is a grouping Kenya, Burkina Faso, and Lagos, where we observe that less than 30% of the women were able to maintain their power in making the decisions of their household purchases for daily needs. We also see that in Kenya, Burkina Faso, and Lagos, the majority of the women that transitioned their power was going into a joint decision making. While in Kinshasa, we see a different pattern, where we find that 53% of the women were able to maintain their power to make decisions about daily purchases for their household. And that the women that transitioned their power to someone, the majority went into transitioning that power to her partner or to someone else. On this slide, we can see the results of our regression analysis. And we find that the patterns are different across countries. But we do find that there is a consistent pattern for age category, where we find that women of older ages are less likely to lose their power to make the decisions of household daily purchases than younger women that are between the ages of 15 to 24. So to conclude, in our survey, we found that there was a profound impact of COVID-19 on household decision-making about purchases for daily needs. We also saw that women shifted their decision-making power to either taking the decisions jointly or to letting their partner be the decision maker. We also find that there is a consistent pattern where teens or young adults are mostly affected by losing their power to make decisions, while we find that the other measures or the other characteristics are different by context. Thank you for being part of this session. And if you have more questions about our data, you can log into our website that is listed here, which is pmadata.org.
Good morning, everybody. Thank you very much for this panel about the impact of the COVID-19 and all the questions about demographic dividend. So here is our menu, our plan. Donc, here in Africa, we have the question of COVID, because this pandemic, and then after that, you are going to see the framework that we have been using in our region in Africa. And then we will see the different phases for the pandemic. So this is a problem international, and so each country reacted in a different way. We have South Africa, we have Nigeria, we see the different African countries. So there is really a very high impact, but the economic impact, so it was really very heavy on the African continent. So we are going to see the different way of transmission. So we have an economic dividend. Yeah, because almost all the countries have been affected by this pandemic. So we will see the work that has been accomplished. And so you are going to see what was the socio-economic impact of this pandemic. So we are going to describe so all the data that we have collected. So we have the NTA method, so that we could see all the transfers that we have analyzed. So all that we have collected because of the age, how it has affected the workplace. So we have collected all this data. So we have developed this based on the work that has been accomplished on the field. So you have all the economic support for all the workers that we have been provided. So we had an analysis to be able to see the economic support that we have been provided in the different regions. So everything that you see here, it was used initially in the framework of NTA. So that is called the SWED. So this is a project of support that is covering most of the country in West Africa. So this is the baseline that we had with this model. So we have been studying the different demographics. And so we have covered the situation in terms of monitoring, and we have been able to analyze the different dimensions. So the dimension, the anti-dimension. So we have an economic dependence in West Africa. So we have again the different dimensions like life cycle dependence, network infrastructure. So we have the different dimensions. So now we have different data. Donc we had Benin in West Africa, Mali, Mauritania, Niger, Senegal. So those are the data that we have been able to compile. So those are the data that we have at the regional level. So we had in each country, we had the COVID inquiries that we have performed. So we have also data from the different departments. From the programs and reports that we have performed. So we also have worked with the data we obtained from different observatories centers. Donc we work together. And so we have been able to have a follow-up of the demographic dividend. So we are going to be able to use this data, and you are going to see so the different scenario. So we started to work very early, since April. So we had at that time 3 possible scenarios. So first, the optimist scenario. So we thought that this COVID crisis will end very early. So we thought that maybe in June 2020, we should be able to resume the economic activities. So the medium scenario, we thought that the crisis maybe will last until the 3rd quarter. So the 3rd quarter of 2020. And then the pessimistic scenario, that the crisis will persist throughout 2020. So the scenario, unfortunately, is the pessimistic one that has prevailed.
So unfortunately, the pessimistic scenario is the one that turned out to be the most realistic scenario. Next, here are our different hypotheses. And these are different hypotheses. We worked with all of the various countries with their demographic observatories to establish those hypotheses. So the countries that I mentioned, here are the results that we attained. we see that there was the economic dependence coverage was drastically reduced in each country. We saw a drop from 42% to 11%. We also saw a reduction in all dimensions of the Better Life Index. The poverty index increased quite dramatically by 4%. Human development dropped by 4%. And access to basic social services was also reduced by 6%. So let's look more specifically at the case of Senegal. We're looking at the economic recovery. So $1,000 billion are involved, and we analyze the impacts on the various domains that I discussed previously. So if we look at the economic dependence coverage again, we saw a drastic drop from 37 to 3%. The Better Life Index dropped by 4%. The poverty index increased by 3%, and human development sadly decreased by 3%. Access to basic social services decreased by 5% as well. And that is in a global sense. Now let's break it down by gender. So these are indicators that show us for Senegal again how work income dramatically dropped. So on the left, you see in the graph, in the solid black line, I'm following that line with the cursor. So that's pre-crisis, and the black dotted line is consumption by age pre-crisis. So in green, you have the optimistic scenario, and we see obviously labor income decrease, but not so dramatically. And on the right, however, we have the pessimistic scenario with the actual labor income drop in Senegal, and how consumption also decreased in reference to the baseline scenario that we had established. So with regard to the demographic dividend, we see 3.5% drop, and we lost 2 million people lost their jobs. And as I mentioned, with regard to gender, so if we break it down by gender, initially, men were not dependent with regard to income. So during the crisis, during this pandemic, we've seen a drop from about 91% to 7%, and women's income dropped from 3.7 to 0.3%. So obviously in light blue, that'll represent men, and pink will represent women. So our baseline was 91.3%, and 6.9 is the impact of the crisis. So those are those figures that I just mentioned. If we look at poverty dynamics, the poverty index increased by 4% for men and 5% for women. So the global index for men, we were at 49.8%, and we saw a drop to 27.8%. Women were at 25.9%. We saw a drop during this crisis to 14.5%. So if we look at the gaps after the recovery plan, and despite this recovery plan, $1,000 million. So the African recovery plan we see the life cycle dependency increase from 6.9% to 47% for men, and for women from 0.3% to 2%. And obviously, there's still a gap that needs to be filled there. So we lost a lot of jobs, and 44% of gaps and 1.7% of, 44% for men and 1.7% of women. Those gaps are still existing. And with regard to poverty, we still have a remaining gap of 0.9% and 0.4% for women. We are continuing our analysis. These countries have asked us to examine the care economy gap. For example, unpaid domestic household work, that was not taken into account in all these analyses. We also want to do a closer analysis, finer analysis, to look at the situation at local level, so that we can target better interventions. So that was the case, that was our study for Senegal. So thank you very much for your attention.
Just to start us off, again, and some of this has already sort of been alluded to, but as we all know, Africa has accounted for a fairly small proportion of COVID-19 cases and deaths. But as of January 12, 2021, we see that Africa has accounted for about, of all confirmed cases, we total about 89 million globally, and about 2.5% of the confirmed deaths globally. But of course, in terms of going beyond the immediate effects on mortality and morbidity, the COVID-19 has, I think, more important, deeper implications that may last for medium to long term, and in the health sector in particular, which is one of the key pillars of the demographic dividend. We have seen short-term disruptions in health sector services that have, for example, been negatively impacted on family planning and sexual and reproductive health services. We've also noted in countries across the continent, suspension of vaccination campaigns. There have been diversion of resources from other critical healthcare needs, such as TB, malaria, HIV. And also importantly, we are seeing a rise in gender-based violence. And also unintended pregnancies, particularly amongst young people. So teenage pregnancies have been on the rise in many countries across the continent. The long-term health consequences are still not well known, and this is something as people conduct studies and we go further into the evolution of the pandemic, which seems to be that it will be with us for a long time, and even as we roll out vaccination campaigns across the globe, it's already being estimated that Africa will really be at the tail end of that campaign, and so we have to contend with the implications of COVID on health services, on health for the long term. We have to think about issues such as mental health, and there have been studies showing that emerging from countries such as South Africa, from countries such as Kenya, showing that there's been an increase in mental health illness, and also on nutrition. Just moving on to on education and training was really massively disrupted, and as you can see on the charts there, we have a map that shows the status of school opening or closing as of March 10th, 2020, May 10th, 2020, and November 10th, 2020. So by May 10th, much of Africa had basically shut down, all learning institutions as part of the COVID prevention measures and mitigation measures. And UNESCO estimates that about 5.3 million learners in sub-Saharan Africa are at risk of not returning to school, or were at risk of not returning to school in 2020. We know that by November, most of the countries at least had partially reopened, and they're trying to open up the institutions this year. But with the new wave, we still don't know how this will really turn out. And there have been challenges despite some of the mitigation strategies that were tried out, including online learning, delivery of curriculum through radio and television. There were challenges that emerged, and these disproportionately affected poor and rural communities that are unable to access these alternative platforms to in-person training. Other issues that are really pointing out on inequalities that the COVID is shining a light on included the female disadvantage in digital learning, but also just in terms of delivery of the curriculum. Curriculum and teacher training was not ready for this kind of situation, if I might put it so. And so the curriculum and teacher training had not been designed for effective delivery on these alternative platforms. And so there have been massive job losses in most of the countries, again, in urban areas where people are engaged in informal sector. This has been massively disrupted, and really it's being projected that this will affect African economies, just as it will the global economies. A UN Economic Commission of Africa scenario study in May 2020 projected a 1.1% growth rate in the best case scenario, or a contraction of up to negative 2.6% in the worst case scenario. And estimates that as many as 19 million people could be deprived of their livelihoods, while up to 29 million people could be pushed into poverty within the context of weak social protection programs. I think one of the main things really to take away from this whole scenario has been around data and measurement. For all that we are able to say, the evidence that we are putting forward to even influence policy, the reality is we still have the large data gaps, and this has undermined effective targeted emergency response and even the long-term response. They have been actually one of the things that has come out of this, of the disruption of routine and periodic data, such as the DHS and census, which policymakers rely on heavily for programmatic action. And these were suspended in quite a number of countries, and we are not sure how this will turn out in 2021, for example, if this situation continues. On the bright side, there have been innovations and adopting new approaches to be able to generate evidence, and we have seen some of the evidence that is out there coming out of SMS surveys, telephone interviews, and other forms of digital surveys. So just as I wrap up, I think the key takeaways, the pandemic is still evolving in Africa, and we are not out of the woods, so we'll see how that goes this year and going forward. But more importantly, taking stock of what the long-term impacts of COVID-19 could be on the demographic dividend pillars is critical for policymakers. Lastly, it's important for us to put in the mitigation measures now and look at what adaptations, what innovations we can put in place, for example, to improve health services that are being affected by COVID-19. How do we make sure that we get our children back into school? Because for a number of countries, almost 1 year of schooling have already been lost. And more importantly, those who have dropped out, it's likely that those from the most disadvantaged communities are the ones who are not going to go back into school. And also addressing the inequalities that are being sharply brought up by the COVID-19 situation. So with that, I'll stop here, and be happy to take up questions, and happy to also share resources with those who would like on the webinar series where we discussed all this. Thank you.
Hello, I'm Prachi Srivastava. I'll be speaking about the broad implications of education, the global evidence that's emerging just now, and also some recommendations that I've made along with UNICEF, UNESCO IIEP, and CPEC Argentina, and the Internetwork Agency for Education and Emergencies to the G20 Summit. We're continuing this work this year as well. While human capital framing has been contested in education, it is incontestable that education is one of the key pillars for human capital, and of course, in achieving the demographic dividend. What are some of the priors that we know in terms of education and education research is that the disruptions that we're seeing right now are going to have both institutional and individual level effects. And what we mean by that is that we're going to see disparities increase within and across countries, and also individual level effects in terms of deprivation will increase within and across different social groups. We know that education has a bidirectional relationship with health. It has shown to have lower risk of HIV infection, reduction in child mortality, in female and male mortality. And we also know that cognitive impairments due to infectious diseases can occur as well. So we're quite concerned about some of the issues that might occur. Education has also shown to have positive societal and individual level externalities. We know that this leads to economic growth in countries. And also, of course, it leads to economic social mobility. It has positive outcomes on citizenship and social cohesion, and it has positive outcomes for personal and household income, labor market participation for women, and for young people as well. What is the global scale of school closures? Now, these data are coming straight out of UNESCO. They were just released last week. We talk a little bit about the first wave, and as a result, in terms of the first phase of the education closures, at its peak, 190 countries had full school closures, and this resulted in about 1.6 billion learners out of school. That is almost, it's about 90% of the learner population, but it's in demographic terms, almost 95% of that total demographic of children and youth in the world. We know that 800 million children still face significant disruptions. And what UNESCO counts along significant disruptions is full closures in 31 countries and 48 countries with part-time or reduced schedules. Schools have been fully closed for an average of 3.5 months since the pandemic onset. And if you actually take into consideration localized school closures, so countries where not the entire system was closed, but just a few regions might have closed, it goes up to about 5.5 months. This is around 2/3 of the academic year. It's very important to note that these are significant in terms of looking at what this means for disruption. What are some of the known risks of school closures? We know, according to the literature from the Ebola and influenza pandemics, that, and also literature in emergency and conflict, that there are significant risks. These range from learning loss and dropout to physical and sexual abuse and violence, increased underage pregnancies, and some of the presentations have talked about this, mental health and psychosocial impacts, reduced emotional support, healthy relationships, and loss of essential services. It's important to remember that schools are not just a place where children go to learn how to read and write, but they're also hubs for essential services. In many countries, as you would know, they provide nutrition, they provide midday meals, they provide allied health services, such as sometimes vaccination campaigns, also providing reproductive health education and services, and psychosocial and developmental services. So really we need to think about education and school closures as being more than just potential learning loss. There are many more other issues that will come up when we look at the data around this. All of these impacts will be compounded on the most vulnerable. And in the particular context that people are working in, you can think about those as being lower income, children with special needs, children from excluded communities, girls, particularly in low income and low middle income countries, and those in vulnerable circumstances affected by crisis and conflict. And prior to the pandemic or entering the pandemic, we know that 260 million children were already out of school, and 50%, up to 30 to 50%, depending on the data, were coming already from crisis and conflict situations. Now, these are some global or some emerging studies that are coming out in terms of COVID-19 and education, looking at some issues. The first is a working paper coming out of the Netherlands. This was seen as a relatively short lockdown and a system that had a high technological preparedness when there was the emergency turn to online schooling. And still, these researchers found a potential 3 percentile point of learning loss. But what the real point here of this study is that the losses were up to 55% larger among students from less educated homes. So again, we want to be cognizant of the fact that the losses that we're going to see are going to be affecting those communities and those children that are already in vulnerable situations, even in contexts that are seen to have relatively stable education systems with good coverage. Another working paper, which, to be frank, I don't know how else to say it, really blew my mind, was a global modeling study on the potential loss of income and loss of that the learning loss may result. And this paper, you can download it, it's available online, showed that there is a potential $10.6 trillion loss of income as a result of just 4 months of school closures for the generation of children that it is affecting right now. And this is massive when we look at it globally. In the current year, the GDP losses can range from 61% in low-income countries to 22% in middle-income countries to up to 9% in high-income countries. This is huge. And so the impact of this is just more than just individual. We need to look at this in terms of societal impact, economic impact, and what that means in terms of recovery. Finally, there is a survey that's being conducted by UNICEF, UNESCO, the World Bank, and in association with the UNESCO Institute for Statistics and UIS. And if you're interested, you can go and find this online as well. It covers globally up to 149 countries. What we're finding is that there's a lost time on average about 47 days, which is roughly a quarter of the school year. And that learning assessments are also being neglected in many countries in terms of low stakes learning assessments. So again, these are just surveys that are documenting the results and the responses as they are happening. I would urge you to follow that. I'm going to end by really focusing on some of the policy principles and recommendations that we are making in the first phase. And we're going to be looking at the equity impacts now.
Dr. Srivastava, I'm so sorry to interrupt you, but we are past time. I'm wondering if perhaps we could save some of these for the question and answer session.
Oh, yes, absolutely. I just wanted to make one point, which is that when we're looking at the policy principles, we want to look at the states as the principal duty bearers. So here, the role of governments and the role of donors to support governments in making sure that, for example, education is financed to the degree that it needs to be financed. That is really the fundamental issue that we want to be looking at. And if you're interested, you can download this document as well on the link, which will be provided in the PowerPoint. Thank you.
Thank you so much to each of our panelists for these fascinating and thought-provoking presentations. We look forward to engaging with our audience members now in the discussion portion of the session, which will be moderated by my fellow subcommittee co-chair, Dr. Kabagenyi. Please do take note that our introductory speaker, Dr. Sikdar from India, was not able to join us for the live session today, so he's not available to answer questions. If you'd like to submit a question or comment for any of the other speakers, please do so using the Q&A button at the bottom of the Zoom screen, not the chat button. And finally, due to the size of the group, we will not be calling on participants to speak, but rather using questions submitted in writing only. Alan, over to you.
Thank you very much, Liz, and many thanks to all our presenters, the panelists. Over to the questions. So I will ask in order of the presentations that we had. Thank you again for the excellent presentation. To Ori, I would like to find out from you, for the unintended pregnancies, why is preferred method not available or categorized as COVID related? And also, would you like to comment about, especially for the survey from Uganda, why MCPR seems very high? And this question goes to Caroline. Caroline, did education or income level have any effects on declines in women's economic empowerment or household decision-making in the PMA survey? It would be very good to hear from you regarding that. Again to you, Carolina. How did decision-making change when baseline questions, or the baseline decisions were made by both women and jointly? Would you like to comment on some of the factors that were influencing such changes? To Latif, what is the strategy? What strategies have been put in place by the government of Senegal or could be put in place to contain the COVID-19 crisis? Any thoughts that you would like to share with us? They're welcome. And to Bernard, again, thank you to all of you for the excellent presentations. Would you like to share with us some of the thoughts or the key lessons that we could carry from the pandemic experience for the data and measurement for the DAD agenda, that is for the demographic dividend agenda? And to Prashi, what do you think are some of the broad policy considerations that should be addressed in reopening schools? I will welcome our panelists to be very brief in the interest of time and to respond to the few questions that have shared, raised to you. Over to you, our panelists. I think I'll invite Aurel to respond to the questions, and then we'll follow in the order of the way you made the presentations. Over to you.
Thanks, Ellen, for the question. So for the first question, it's because the question had two parts in the survey. We first asked women if the pandemic affected their ability to avoid or delay getting pregnant, and then we asked why. So that would be because women answered yes to the first part of the question, that it was attributed to the pandemic. For contraceptive prevalence, that's a good question. The latest PMA in Uganda, I believe, had prevalence at 37%. In our study, the sample is not nationally representative, if only because we are recruiting women who are using VMO 321 service, but also because for the panel survey, we are restricting the sample to current users and women with unmet need. So that would be logical, probably, that the prevalence would be higher. That being said, the goal of the study is not to quantify necessarily. It's more, because it's longitudinal, to think about it as a surveillance system to see what's happening over time to the same sample. So I'll stop there and maybe hand it over to Carolina for her questions.
Thank you. Carolina, you're welcome to respond to the questions.
Thank you, Aurelia, and thank you, Alan. Both of the questions are great. So as for the education and income question, so across our models, we found that education was not, in fact, a significant factor associated with women's losing their ability to make the household decisions of everyday purchases. It was not significant across all 4 countries. As for income, we do not have a metric that asks women in the survey what is their household income. However, we do proxy this income by estimating a wealth index. But this wealth index is based on the assets of the household. So it's not a reflection of income per se. And we cannot claim that if this income is coming mainly from the partner or if it is coming from the women. So a way of capturing that, because we did think that it was interesting to know, like if a woman is working for cash, if that is affecting their ability, their empowerment inside her household, then we included a variable that asked women prior to COVID in the baseline survey if the woman was working and if she was working for cash. And we did find that this variable was significant in Kinshasa. It was not significant in the other countries, but in Kinshasa, it seemed that it worked as a shield against women's losing their economic empowerment and making the decisions. As for the second question, we did measure. So remember that the results that we presented here today were when the women was the decision maker at baseline. And then this question is asking, so what happens if the decisions at baseline are made either by the women or are they made jointly? So when we look at that, we found that there were some changes between baseline and COVID, but those changes were smaller. As for the factors that were associated with those changes, we found that they were similar to the patterns that I presented here today. And we did think that it was interesting that women that were working at baseline for cash were less likely to lose their decision-making power, even though when the decisions were made either by her and her partner.
Thank you, Carolina. Latif, would you like to come through for the questions?
Yes, good morning to everyone. Alan, good morning. Thank you for the questions. In Senegal, we have a second recovery plan. So we had a strategy. So we have a new recovery plan that has been launched. So it's in cooperation with the government of Senegal. But the problems that we have, so this is the situation of women. So in the sub-region, so we had an informal sector. So because the women, they have very unstable and precarious employment. So in Senegal, so because of the crisis, everything has been blocked, locked out, all the informal sector. So during the lockdown, everything has stopped. So the strategy of the government, it was to launch a recovery plan with a very important social aspect. So we have set up and distributed different kits for the most impoverished areas. So this was already existing before the pandemic, but we managed to really amplify. So that way we can help a much larger number of families. So this is in reference of the social sector, but we have also the education and the private sector. Many companies, so they had a certain level of salaries. So unfortunately, they had to lay off some workers. So what we can say for the pandemic, so this recovery plan, So at least for some of the companies, they were able to keep the workers. So people who were working in the private sector, but we had a very strong impact because of the lockdown of the informal sector. So this is what I wanted to answer this first question. Thank you.
Thank you very much, Latif. Bernard, would you like to respond to the first question that I shared with you?
Yeah, so thanks. I think for me, the COVID-19 situation has been quite an eye opener, especially on the issue of data and measurement. There are two things to say there. One, I think it have just sharpened, or it have really highlighted the need for continuous data collection, especially by government agencies. So really strengthening the statistics bodies in countries to do that, but also to have to have a platform for rapid response, because what we are seeing is that even in terms of targeting response to COVID-19, or even supporting social support from the government, the data was not there. So programs were not being, really supported by strong evidence. But on the flip side, we've also seen quite a bit of innovation and people really coming together very quickly and adopting new ways of collecting data to respond. I wanted to just tie that to I think for the demographic dividend, one of the issues at the moment, we are really addressing evidence needs for the short-term implications and so on. I think for the demographic dividend in Africa in particular, some of this estimating the negative impacts, or estimating the impacts, the long-term impacts, especially in human capital development, is going to be very critical. I saw in one of the questions someone asked whether this will affect the window of opportunity to harness the demographic dividend. I'd say that probably if you look at on the issue of unmet need, we saw disruptions there, but probably that won't be the most. We are likely to see recovery as long as we put our efforts towards making sure that services are available, commodities are available. We can address the unmet need disruptions quickly. What we need to be careful about is actually issues such as the people dropping out of school, for example. How many of those children are going to go back to school, and how will that really affect? So the age structure may change, but there's going to be long-term implications in the quality of the skills that will be affected by this whole episode. And so that is especially on human capital development. What can we estimate? Can we estimate, the long-term impacts, and can we put in place now strategies to actually address that in order not to see a minimized demographic dividend, rather than really enhancing the potential of that dividend? Thanks.
Thank you very much, Bernard. Archie, in the interest of time, in just less than a minute, do you want to comment, and then perhaps you respond in writing in the chat room? Would you like to do that? We've run out of time.
Yeah, which is unfortunate, because I think the question is, the issue of education is affecting this entire generation. So actually, it's a little bit, I think one of the main policy imperatives is for governments to realize that we are very much focusing on the short-term issues, and the long-term issues for education, where it seems to always be crowded out, is really what's going to cause the difference between recovery, societal recovery long-term, and disaster. And I'm not being a fearmonger. These are actual modeling studies. We're seeing results coming out from a number of country contexts to see a host of very negative consequences for our economies, for our societies as a result of education disruption. And we're also seeing reduced budgets for education. We're also seeing, and we're coming into this in a situation where donors have continuously underfinanced education, and about a third of countries have underfinanced education for more than 20 years. So these are the kinds of big picture questions that need to be addressed. And I hope that in all of the presentations, the role of education in all the various aspects has been highlighted. So I hope that the research continues to go along those ways.
Awesome. Thank you very much to all our panelists for the excellent presentations and also to responding to some of the questions. The audience, thank you for the very many questions that you submitted. I would like to invite, again, in the interest of time, to invite Kaitlyn to give us the closing remarks, and she'll make a comment regarding the other questions, how we can go about it, the ones that we have not been able to accomplish. But thanks again to the panelists for responding to the questions very well. Excellent.
Thank you so much, Alan. So on behalf of the chairs of the Demographic Dividend Subcommittee, I want to thank each of our panelists for their insights and all of our participants for your engagement during this really fruitful discussion. We know we always need more time for questions and answer, so we will be making the contact information for our panelists available, I think through the chat or potentially through follow-up, but we also invite you to join us on social media to continue discussing your questions and insights and responses using the hashtag ICFPDD. We also really welcome you to get in touch with us to join the ICFP Demographic Dividend Subcommittee as we prepare, hopefully in the coming year or so, to meet together in person. It's clear that as policymakers continue to grapple with the immediate crisis, the long-term effects of the COVID-19 pandemic on human capital development represent a significant threat for efforts to achieve a demographic dividend in many countries. And at the same time, this global crisis has underscored the need for concerted investment in the multi-sectoral development programs that build resilience to shocks, including, of course, family planning. As the full economic consequences of the pandemic unfold, resource constraints will make it more important than ever to identify and prioritize high-impact, cost-effective strategies and interventions across each pillar of the dividend. Leaders will continue to need accurate data and information to respond quickly and effectively. Innovations in data collection are generating real-time learning to inform adaptive policy and program measures. In Senegal, data on the labor force effects of the pandemic are now being used to inform the national recovery strategy. In Uganda, preliminary survey findings underscore the importance of strengthening new or underutilized family planning service delivery approaches that bring access closer to home. Despite the challenges, countries are already identifying and implementing these and other solutions to mitigate the effects of the pandemic on human capital, and such strategies must be widely shared and disseminated. So thank you again to everyone who took the time to join us today. Please check out the Demographic Dividend community page for information and resources, as well as copies of this recording and presentations, or of course to contact the panelists. We can't wait until we're able to meet together in person again, and we wish each of you health and safety until then. Thank you very much.
power to be seen across the world. We're not the future, we're the present. Invest in us and you will see the world is changing.